Good afternoon, everybody. Today I'm going to present the most recent updates in hemodialysis. Before presenting the data, I would like to congratulate Professor Magdi Sharqawi for the success of the 10th Annual Dialysis Conference. And this, one of the important messages that I learned from this conference is working in a team. So team means together everyone achieves more. So congratulations for all nephrology department in Ain Shams University for their teamwork and their persistence to for the success of this meeting. So I reviewed more than 300 articles, and I'm going to focus on some important data regarding I start with the introduction, followed by some points about vascular access, and then dialysis prescription and using dialytic modalities for extracorporeal treatment of toxins, and then update of anemia, complications, oxidative stress, inflammation, infection, predictors of mortality in hemodialysis, and I'll end with some funny data in a miscellaneous sector. To start with, we should incorporate patient in everything. And this is a survey of more than 50% of dialysis facilities in the United States, showing that patients are more satisfied if we give them time with a large number of nurses, and they are not satisfied and offering lower scores for profit facilities and facilities owned by large dialysis organizations. The message is we should put patients in focus, because putting patients in focus will improve the service that we are conducting. One important point is we should avoid conflicts of interest, and the lack of transparency is not only poses a major barrier for evidence-based healthcare policy, but also deprives patients of critical information. Regarding vascular access, all of us advocate the use of fistula as the preferred permanent vascular access in hemodialysis. One of the most important issues and the barriers is the lack of maturation. So this is a very recent article addressing the issue of prediction of arteriovenous fistula clinical maturation, depending on post-operative ultrasound, and this is the editorial comment, and the key message is careful post-operative measures of flow, diameter, and depth can bring more science to the process of clinical maturation. So we need a skillful surgeon or interventionist. Secondly, we need to put it in our interested and important focus by assessing the patient before and after, as you see in this post-operative measures of ultrasound data. Another article in elderly patients above 67 years for whom dialysis was conducted through catheter and then through permanent access, either fistula or graft in this number of patients. And the authors addressed all these outcome points. So the unsuccessful use of vascular access, interventions to make vascular access functional, primary patency loss and abandonment. And you can see here clearly the figures and numbers within for each outcome studied in comparison to fistula first assumption. So in this study, the likelihood of access to be unsuccessful, which is bad news, is unfortunately more common with fistula, 51% in comparison to 45% in the grafts. And this is contradictory to the fistula first assumption. Among elderly hemodialysis patients, a higher proportion of new AV fistulas versus AV grafts are not successfully used for dialysis within 6 months. And also the ratio is 1.8. interventions to make vascular access functional. Again, it is more common used in fistula. So it is again contradictory to the fistula first assumption. An intervention to achieve successful use of dialysis was required more frequently in patients with an AV fistula versus grafts. And odds ratio is 2.6. Access abandonment in first year after initial use, here the fistula is better, and this is consistent among elderly hemodialysis patients that AV fistulas had a lower likelihood than grafts of failing within 1 year of successful use. So the problem is difficult start of fistula, and the advantage is better end if it is if the function of the fistula is offered. Frequency of access interventions required within the first year. Again, here it is bad news in fistula. It is better in fistula because the rate is higher within the grafts. And this is consistent to fistula first assumption. If fistulas required fewer intervention than grafts, here relative risk is 0.77 and the confidence interval is less than 1. The last point in the outcome variables studied in this article is median duration of catheter dependence. Again, it is bad in fistula, 3 months in comparison to 1 month in the graft. So it is contradictory to fistula first assumption. Patients receiving fistula had 2 months longer catheter dependence before successful use as compared to grafts. So if you fix this table, fistula is difficult in a start to be functioning, but if it functions, it will be better on the long term. This is why it's better when we select any vascular access to sit together with the patients and discussing the pros and cons and the advantages in the process known as trade-off in vascular access selection in elderly patients initiating dialysis through catheters. These data, this is another article addressing the vascular access in elderly, including more than 8,000 patients aged above 80 years, and the data suggested that initial central venous catheter use with later placement of an AV fistula may be an acceptable options among elderly hemodialysis patients. And another article showing the link of the use of catheters either on unadjusted or adjusted analysis. Here you can look, the odds ratio for central venous stenosis is 14-fold higher if we use the tunneled catheters. So we don't like catheters. We hate catheters, but we should live with them because sometimes this is the only vascular access that we can conduct with the patients. So this article addresses the pros and cons, the advantages and risks, benefits and risks of using central venous catheters. You can read all the benefits here. High likelihood of successful insertion, doesn't require venipuncture, can be inserted into multiple sites, allow for maturation of fistular grafts, bridging dialysis, allows measurement of hemodialysis variables, can be used immediately after insertion without delay, ability to be used for months to a few years, ease of use, absence of cardiopulmonary recirculation, relative ease of managing thrombotic complications, availability of catheters, catheter repair without need for exchange, low cost of placement and exchange. All these are benefits. However, as I mentioned, I don't like catheter, but sometimes it's the only solution for our patients because the risks are so many. There are insertion-related risks and catheter use-related risks. So insertion risks include hemothorax, pneumothorax, air embolism, arrhythmia, pericardial tamponade, atrial and venous perforation, dissection and occlusion. And the risks after the use of catheters include luminal thrombosis, infection, poor function, unreliable blood flow, limited functional longevity, inflammation, increasing rate of hospitalization and death, increased cost, of treating complications, central venous stenosis and fracture, vascular growth, fibrin sheath formation, fibrin tail or flap formation, patient cosmetic concerns. So a lot of risks. Again and again, we should learn how to use catheters, and I think reading this article is very important because it includes a lot of issues regarding the catheter use. The following sector is dialysis prescription and using extracorporeal treatment for toxins. So this is EODD. This is every other day dialysis. So in comparison to thrice weekly, you can say every other day dialysis means 3.5 sessions per week. So it is a modest increase in dialysis in comparison to daily dialysis. So I think it is an option, and since 3 years, one of our recommendations here in Mansoura during the international hemodialysis course that we advocated more frequent dialysis, and I think if we can apply every other day dialysis exactly, it will be one of the solutions for increasing the frequency of dialysis. But the problem is in center hemodialysis, it's quite difficult to run dialysis on Saturday, Monday, Wednesday, followed by Friday, Sunday, Tuesday, and Thursday. So, but if we solve this administrative problem, I think it will be a modest solution to increase dialysis. Another issue to increase dialysis is to offer nocturnal hemodialysis, either in home or in center hemodialysis. I think it can give more time for patients for increasing dialysis adequacy. Regarding the issue of conventional dialysis, which is currently considered a conventional dialysis, here, this is an article advocating the use of hemodiafiltration. So in the past, the conventional dialysis was a standard quality of water, acetate dialysate, dialysis machine without volumetric control, and low flux dialyzers. And the authors within this articles showed that the conventional dialysis changed from this past standards into the current standards using high quality of water plus double reverse osmosis, ultra pure bicarbonate dialysate, dialysis machines with the possibility of online hemofiltration and hemodiafiltration, high flux dialyzers. So the trend is toward more and more quality of the dialysis. One of the important supplements of nephrodialysis transplantation this month is this supplement under the title Expanded Hemodialysis, Translating Innovation to Clinical Outcomes. This supplement includes a lot of reviews. One of them is concentrating upon large uremic toxins. This is an unsolved problem in end-stage kidney disease. As you see here, all these are the toxins that can increases the risk of cardiovascular problems, and all of these are considered the middle molecules. So again, how to get rid of middle molecules? We should use the recent advances in hemodialysis, either hemodiafiltration or using expanded hemodialysis. This is why they concentrated in expanded hemodialysis. Is there a difference between expanded hemodialysis and hemodiafiltration? Expanded hemodialysis depends upon the dialyzer itself. To have dialyzers with the abilities to get rid of middle molecules or large molecules. So these are the traditional small molecules, and these are the middle molecules, including beta-2 microglobulin, leptin, myoglobin, and here the large molecules, including myoglobin, the interleukin-6, hepcidin, all these are large molecules, and we would like to get rid of all these small, middle, and large molecules, but certainly we don't like to lose albumin. So expanded hemodialysis may be another solution beside the hemodiafiltration to improve everything, increase. But when we apply expanded hemodialysis, we should also offer the comprehensive care, including dietary intake, the improvement of the cardiovascular disease, everything. We should look at the comorbidities. So do we live until we find the membrane closer to native kidney? I am sure whatever we have, it will be impossible to simulate native kidneys. But even if it becomes closer to native kidneys, I think it is a big dream. This is another advantage, is using automated wearable artificial kidney, wearable artificial kidney or implanted artificial kidney. This table summarizes weight, power requirement, fluid requirement, stage of development. So here there are trials in human, FDA clinical trials, and here for implanted artificial kidney, it is conducted in animal models, and strengths and limitations. And this is the appearance of implanted artificial kidney. It's very smart, even including proximal convoluted tubule cells to offer tubular functions. It's connected to the blood compartment and connected to the bladder, so it simulates kidney transplant. And I think the problem is they will need repeated surgery to solve their problem. So we are waiting the advancement in this issue. Regarding bioimpedance, can we use bioimpedance in the clinical to guide us for fluid management in patients receiving dialysis? This is the title of this review, and these are the key points of the article. There is insufficient evidence yet to recommend that bioimpedance spectroscopy is used routinely to manage fluid status. Nothing replaces clinical evaluation. There is considerable heterogeneity in studies that have investigated the added value of bioimpedance in setting the normally hydrated weight, especially in terms of how the information is applied by clinicians. Setting an aggressive bioimpedance target, for example, fluid depletion, post-dialysis may accelerate loss of urine output. Bioimpedance does add additional prognostic information, and it can both lead to a change in fluid status and blood pressure, as well as monitoring the effect of an intervention designed to change fluid status. However, the conclusion in one statement, the usefulness of bioimpedance spectroscopy in guiding fluid management in dialysis patients is not yet clear. So we need further studies before recommending bioimpedance. And we may recommend even using clinical plus some easy modalities like measuring IVC diameter, for example. And there are some centers doing training for nurses to measure IVC diameter. This is a very interesting title, Kid-Nemes, regarding the acid-base disturbance. What does it mean? It is Latin words, means that we neither in excess, neither acidosis and nor alkalosis, because sometimes alkalosis is a reflection of poor protein intake. So we need serum bicarb to be normal before dialysis, and we don't like excess alkalosis because both acidosis and alkalosis are associated with poor outcome. Regarding dialysate prescription, dialysate potassium. Here, if you look at this table that summarizes many issues related to prescription of dialysate potassium, one of them is rule of 7. Rule of 7 means 7 minus pre-dialysis serum potassium. If you have serum potassium less than 4, you need dialysate potassium 4. If it is above 6.5, you need dialysate potassium 1 or even 0. So if we should be dynamic when we look at the potassium in serum and dialysate, because in early hours, you'll find dramatic reduction of potassium, 1 millimole per hour, and then static later on. And the most important is rebound of serum potassium after ending of dialysis. So we should be dynamic when we look at dialysate potassium. We don't like aggressive shift in potassium. Aggressive reduction of potassium during dialysis may be associated with problems like arrhythmias, etc. Another issue is to keep dialysate potassium in the conventional range and look at diets and the other issues. So please fix this table and look at different parameters. Here, the regarding dialysate sodium. So dialysate prescription is very important, and here all these factors affect our decision regarding the dialysate sodium. If you use higher dialysate sodium, this means sodium gain and increasing volume between dialysis session. And if you use lower sodium, it may be also problematic. So where we are going, this is the what's meant by co-vadis, where we are going. I think it's better to look at serum sodium before dialysis and keeping dialysis sodium within plus minus 2 millimole from the serum, and this is my opinion. Up to this moment, we need further studies, and this is why the dialysate in sodium remains controversial. And this study discusses the recommendations for research, including the need for studies and meta-analysis for the deciding which will be the best for the dialysis, and the recommendation methodology, and you can read all these data within this article. This is very interesting. If you have a patient and serum sodium before dialysis is very low, so how to conduct the dialysis in a patient with severe hyponatremia? And there is no evidence-based recommendation, but I think this table within this article is interesting because using a small surface area dialyzer, minimizing blood flow rate to 200 milliliter per minute, decrease dialysis time, short dialysis session, use lower available dialysate sodium concentration, the lowest available, concurrent dialysis flow, dextrose 5% infusion into the venous arm of the dialysis access, and the hourly monitoring of serum sodium concentration and the adjustment of the dextrose infusion rate as needed. Because yes, there is some protection against the pontine, central pontine myelinolysis, but I think it is not without harm to fast increase serum sodium. So we should be careful to allow gradual increase of serum sodium to avoid central pontine myelinolysis. It may be also the best is to use continuous renal replacement therapy, but because of lack of availability, we can depend on these issues. Regarding poisoning, can we use extracorporeal treatments to manage poisoning? What are the rationale? What is the rationale, and what are the algorithms that can guide us? And I think it's very interesting algorithm. We should ask ourselves some important points. Is the exposure to poison likely to cause serious morbidity or mortality? If yes, can the poison toxicity be prevented or reversed by antidote? If no, can the poison's toxicity be minimized by treatments that prevent absorption and or enhance elimination? If no, if the poisonous endogenous clearance is above 4 milliliter per minute per kilogram? If no, if the poisonous volume of the distribution is in this range from 1 to 2 liter per kilogram? If no, what is the percent of poison is protein bound? If it's above 95%, the best extracorporeal treatment will be a plasma exchange. If it's between 80 to 95, hemoperfusion the best. If it's less than 80% protein bound, we should ask ourselves about the molecular weight. If it is above 50,000, therapeutic plasma exchange is the best. If it is between 25 to 50,000, high cutoff and the medium cutoff hemodialysis or hemoperfusion. If it's between 15 to 25,000, hemofiltration. If it is 15,000, high flux hemodialysis. So this is how we go to the extracorporeal treatment and what is the best modality to be used. And this table summarizes some of the poisoning So if we have tricyclic antidepressants or digoxin, the recommendations are against using extracorporeal treatment. And if ask you regarding the digoxin, is it dialyzable? It is dialyzable, but the fraction present in the blood is very minimal. So and the volume of distribution is big. This means that dialysis is inefficient in managing digoxin intoxication. And the best way is to use fabfragmine, and to be followed later by plasma exchange to remove digoxin fabfragmine altogether. Regarding the recommendation is to use extracorporeal treatment for all these poisons or toxicity. Regarding levofloxacin, it is interesting in this article to find two case reports for whom neural toxicity of levofloxacin was successfully treated by extracorporeal treatment. This is the mechanism of levofloxacin-induced neurotoxicity is either inhibiting gamma aminobutyric acid, or stimulating NMDA, N-methyl D-aspartate, leading to increased downstream neural excitatory pathways, neurotoxic side effects including seizures and myoclonus. So if the patient is treated with levofloxacin and followed by neurological toxicity, after these two case reports, we can think of dialysis. Regarding hemodialysis for treatment of levofloxacin, this is the two case reports, and this is the molecular weight of the levofloxacin. It is a small, and it is 24 to 38% protein bound, not high protein bound. The mean volume distribution is modest. So this pharmacokinetic profile allows for extracorporeal treatment success. And this is the details of the poisons, and this is a number of extracorporeal treatment performed for poisoning according to different toxicity. And here the majority of extracorporeal treatment are through hemodialysis. And if you go to this free site, Blood Purification in Toxicology, reviewing the evidence and providing recommendation, if you just you write this, you will find the executive summary of recommendations. You will find different substances. If you click on any one of them, you will find details. For example, if you click on metformin, you will find here the general recommendation for metformin intoxication and how to deal with, and what are the indications, the precautions, and the modality of choice for this toxicity. Let me go to the anemia update. Since 1 year, we are insisting on the treatment of hemodialysis associated anemia is to start with iron, and iron. So iron is crucial. Here I just want to modify. We don't like excess iron, because excess iron is not without side effects, especially for patients on peritoneal dialysis and patients with hepatitis C. And do we have methods to monitor iron within the body? We have iron stores to assess the need, like ferritin and transferrin saturation, hypochromic red cell, etc. But this is very interesting because it shows liver iron concentration measured by MRI, magnetic susceptometry. It is very interesting, and we have MD thesis in Mansoura about this issue to measure liver iron by MRI in hemodialysis patients. Regarding ferric pyrophosphate citrate, I am totally convinced by the use of ferric pyrophosphate citrate in dialysate, because it will increase iron by the physiological manner, because it increases iron by approximate 5 to 6 milligram per dialysis session. It is approximate to the physiological correction of iron deficiency. The problem is we cannot supplement ferric pyrophosphate except on the fluid compartment of the bicarbonate. So if we use powders for bicarbonate, so it will be impossible to add it to the dialysate. And this is a very interesting article in Pediatric. Here they used ferric pyrophosphate citrate administered via dialysate, if we are using fluid bicarbonate, or intravenously to pediatric patients. So it can be given intravenously for pediatric patients. Another issue in the update is hypoxia inducible factor stabilizer. This is the new novel compound induces erythropoietin secretion through liver effects in chronic kidney disease and healthy volunteers. So this initiative study and the pilot study, and we need to look at the future. Regarding the issue of optimal hemoglobin level, all of us are aware by the KDIGO guidelines and a lot of guidelines that are summarized within this table, and you'll find this is the level between 10.5 to 11.5, less than 12. So this is the target hemoglobin. Here I want to give two comments. Number one, no target hemoglobin for iron deficiency. So if we have absolute iron deficiency, we should correct iron. If it raises hemoglobin, it will be okay, accepted. But the target hemoglobin is for ESA therapy. And I have a question. If in the future we use hypoxia inducible factor stabilizer, the optimal hemoglobin level will follow ESA target level. I think it is different, because the use of hypoxia inducible factors stabilizers are associated with gradual rise of erythropoietin. So this is an important review. Compared the ESAs versus hypoxia inducible factor stabilizers. So pros and cons for each of them are illustrated in this table. So pro for ESA use, ESAs are effective. We have long clinical experience, acceptable safety profile, and no bill burden because they are injected. The pros for hypoxia inducible factor stabilizers, they are effective, stimulation of endogenous EPO, no hypertension, higher suppression of hepcidin, not influenced by inflammation, and they even correct hepcidin. So it improves the bioavailability of iron, better iron absorption, utilization, chemical drugs, LDL cholesterol reduction, effective in other conditions. So these are the pros and cons. And I think oral treatment is also exciting. So can consider it in the cons of bill burden, but it is also advantageous to have the hypoxia inducible factor stabilizer in an oral form. Cons for ESA therapies: high EPO levels, small hypertension risk, endothelium stimulation, small cardiovascular risk at high doses, or excessive hemoglobin target. So this is why we should have target for ESA therapy. A small oncologic risk, the small thrombotic risk is still expensive, not effective in inflamed patients. And we have a big headache known as ESA hyper-responsiveness or ESA resistance. Regarding the hypoxia inducible factor stabilizer, no long-term data, potential VEGF increase, HDL cholesterol reduction, bill burden, unexpected effects following the possible activation of several genes and pathways, selectivity and oncologic risk in some issues, unknown effects, damage because of chronic hypoxia state, exhaustion of EPO stimulation over time, and pulmonary hypertension. So we have pros and cons for each of them, but we are waiting further evidence from the new literature. Regarding the complications in hemodialysis, so first of all, we should consider hemodialysis as a model of unphysiology or extreme physiology in vulnerable patients. So we have ultrafiltration that's associated with reduction of blood volume. Hemodialysis is associated with thermal stress, increasing core temperature will lead to skin vasodilation, and this will be associated with reduction of effective volume. So a lot of issues, hypoxia and tissue oxygen delivery is reduced, and so at the end we are dealing with unphysiological environment. One of the important complications is cardiovascular disease in dialysis patients, because the most important cause of death among CKD and dialysis is cardiovascular diseases. Why? Cardiovascular risk is increased with dialysis because of the environment of dialysis. You can find here a lot of factors that can lead to cardiovascular disease, including the uremic toxins, CKD MBD profile, FGF23, lack of clotho, cardiovascular calcification, atherosclerosis, endothelial dysfunction, myocardial fibrosis. All these issues lead to cardiovascular disease. Regarding intradialytic hypotension, it is a very important, and it is considered one of the important complications after dialysis. So we need techniques to improve intradialytic hypotension, and these are the key points. Cooling the dialysate. I am so convinced by cooling dialysate without inducing the extreme sense of non-comfortable dialysis to our patients without shivering. So cooling the dialysate reduces intradialytic hypotension, is safe and doesn't occur any cost, doesn't need any extra cost, is the first line strategy in intradialytic hypotension prevention. Reducing interdialytic weight gain and accurate determination of target weight are important on an individual patient basis to avoid unnecessary excess ultrafiltration rate. Sometimes the levocarnitine supplementation may be tried, but be careful because you can find some contradictory data because intradialytic hypotension may be higher if the level is increased to up to a certain level. Sodium profiling is not recommended to reduce intradialytic hypotension. Why? Because of the fear of sodium loading, increasing thirst, and larger interdialytic weight gains. So these are the applied points. Some funny situation. Can we use dialysis while we are immersion enhanced fluid redistribution? So we put the patient in a tank, water tank, and his neck is out. I think it's fantastic. But here it was conducted in our respective randomized crossover in few number of patients, and it was successful to reduce intradialytic hypotension. This is a large data about the relationship of intradialytic hypotension with mesenteric ischemia. Here, the cases of mesenteric ischemia were 626 patients, and they compared them to 2,400 patients without mesenteric ischemia. The definitions of intradialytic hypotension are either nadir 90, so systole reduced less than 90 and less than 100, or fall in systolic blood pressure by 20 millimeter mercury, or fall by 30 millimeter mercury, or nadir 90, they combine nadir 90 and the fall 20, nadir 90 and the fall 30 in systolic blood pressure. What do you see? Black one refers to the patients with mesenteric ischemia. So mesenteric ischemia is associated with nadir 90, nadir 100, nadir 90 with fall 20, nadir 90 with fall 30. So again, intradialytic hypotension may be complicated by mesenteric ischemia. Regarding the hyperthyroidism, it is still a headache in hemodialysis, and one of important headache is how to assess and to measure BTH. So this is in seminar and dialysis you'll find the practical consideration. So this is the first generation of the assay using monoclonal antibodies. It's not so specific. This is the second generation. Here this is a molecular BTH and how they start the detection and the capture. And this is the third generation. So this table summarizes the advantages and disadvantages of different assays. So first generation is now obsolete. Second generation is the most widely used and studied, less expensive, adopted by current clinical practice guidelines. But the disadvantages include cross-reaction with C-terminal BTH, wide range of inter-method variability. But still, second generation is the most commonly used and recommended. For third generations, direct measurement of biologically active BTH doesn't cross-react with C-terminal beta-H, it may correlate better with mortality. But again, third generation assays are more expensive, less widely used, and not adopted by current practice guidelines. And this is beta-H 1 to 84, the ratio between total beta-H to C beta-H may correlate better with bone histomorphometry, gives accurate information for both biologic active and inactive hormone. More expensive as it requires utilizing second and third generation beta-H assays, conflicting evidence about its diagnostic and prognostic value. So it seems that we are still using a second generation. Regarding drugs against hyperparathyroidism, all of us are aware by Sinacalcet, orally given drugs, that was FDA approved on 2004. The recent approved molecule is this one, ethyl-calcetide. It is given intravenous, so it is single dose, either 2.5, 5, and 10 milligram vials, administered intravenous thrice weekly at the end of each hemodialysis treatment. And so this is the effects on parathormone. The newly introduced parenteral calcium mimetic is more potent in reducing hyperparathyroidism because it is more potent in controlling hyperparathyroidism. It's also associated with more hypocalcemia. But I think the more potent in reducing VEGF, it is an advantage. One of the headache in the dialysis is vascular calcification, because every day we have many headaches about the promoters of vascular calcification, including excess phosphate, calcium, vitamin D, activin A, BMB, ostocalcin, ostonectin. All these are promoters of vascular calcifications, and inhibitors including pyrophosphate, phytoin A, bone morphomotor protein, matrix glyprotein, magnesium, osteopontin. So here I would like to comment on two issues using measuring magnesium, and we can accept a mild high level of serum magnesium, because magnesium is a good friend for us, and to avoid hypomagnesemia, because hypomagnesemia is bad issue. So we should look at serum magnesium and dialysate magnesium and dietary magnesium. And the second issue is activation of matrix glyprotein by using vitamin K2. So we are waiting further evidence for the studies that showing even the trap ligand that block this, the site, the activin A binding to its receptor. So a lot of issues are added to the literature of vascular calcification, but the key message from my point of view is to prevent occurrence of vascular calcification, because when it occurs, it will be late. So if we want to be successful, I think we should deal with this issue before its occurrence. Regarding cognitive impairment, the cognitive impairment in non-dialysis and after transition to dialysis, this is from data from the chronic renal insufficiency cohort CRIC study, documenting that the black color means no cognitive function. The gray one means the cognitive impairment. As you see here, peritoneal dialysis is associated with significant reduction of cognitive impairment, and avoidance of catheter here is associated with significant reduction of cognitive impairment. And you can see here clearly that BD and avoiding catheters are associated with reduction of the, according to these multivariate logistic regression analysis models, the association of pre-dialysis cognitive impairment, dividing using these models, as you see here, BD as first dialysis modality and the CVC catheter avoidance are associated with significant lowered level of cognitive impairment. And even here again the data are showing transition outcome. Again, the data are conclusive for avoiding catheter as we can. Function decline, Dialysis is a restricting for functional mobility of the patients. So how to break the cycle of functional decline? I think it's one of our, should be one of our aims. And as you see, in dialysis, there is lower physical activity, especially if age advances, because a lot of issues related to frailty and geriatric syndromes, physical disability, functional decline, using polypharmacy, comorbidity burden. So we should think of all these points to improve functional decline. Regarding oxidative stress, inflammation, and infection, oxidative stresses are so frequent in dialysis because, as I mentioned before, hemodialysis is not physiological. So we should strive to offer the high quality dialysis by using new techniques. And this is a very quiet and the basic table showing oxidants, a lot of oxidants. And here the antioxidants and the potential interventions for ameliorating oxidative stress in hemodialysis patients include dietary interventions like limited salt intake, controlled fluid intake, Mediterranean style of diet, low carbohydrate diet, supplementation with fiber, flaxseed and virgin argan oil. All these are dietary interventions to reduce oxidative stress. Smoking cessation, so lifestyle is very important, crucial. Improvement of sleep disorders, and we should learn how to have a healthy sleep. Optimum glycemic control in diabetics, adequate blood pressure control, treatment with ultra-pure dialysate. It's very important to avoid excess inflammation. Using biocompatible dialyzers, high flux, vitamin E, but we need more and more evidence for these points. Online hemodiafiltration, short-term use of central venous catheters or avoiding catheter if we can. Functional arteriovenous fistula, a proper correction of anemia, slow iron administration was possible, limiting the excess iron, as I mentioned before, antioxidant supplementation, but we need further studies for all these points. However, I'm stressing on the that we should take the patient overall, so we should be holistic in our management. We have the dialysis parameters to be changed toward the optimum dialysis, and we have the patients who should help us by following the proper healthy lifestyle. Here, dialysis is associated with complement activation, so this is bad issue, inflammation. Another issue, another study shows association of aromatic toxins and inflammatory markers with physical performance in dialysis patients. And this study is still in press, shows effect of symbiotic and probiotic. Probiotic means to supplement by bacteria, and here synbiotic fibers plus bacteria. On serum levels of endothelial cell adhesion molecules in hemodialysis patients. It is a randomized controlled study, showed that symbiotics and probiotics are associated with significant reduction of ICAM and VCAM molecules. Hemodialysis-related amyloidosis and its link with the link with beta-2 microglobulin is already known. However, if we are working in an environment of inflammation, inflammations precipitate the amyloid fibrils, beta-2 microglobulin, so we should combat inflammation. This is to show the supplementation of short-chain fatty acid, the impatients on maintenance hemodialysis. This is a pilot study, showed that supplementation of short fatty acids can help the patients in getting rid of inflammation, as shown from reduction of many of inflammatory profile parameters. This is very interesting because it is practical. Don't forget that the environment of dialysis is an environment full of inflammation predisposition. It's especially failed renal graft. We shouldn't forget that our patient, if he was transplanted and now is dialyzed because of graft failure, we shouldn't forget that this renal graft may be a source of inflammation. Vascular access using catheter shouldn't be forgotten. A lot of issues in dialysis can lead to chronic inflammatory states. This is why the approach to dialysis patients in a chronic inflammatory state include thinking of inflammation whenever you find erythropoietin resistance. Think of inflammation when you find elevated ferritin and C-reactive protein. And this is the treatment modalities. Dialysis catheter present. If it is present and you documented inflammation, please think of catheter removal. Think of occult infection or of clotted arteriovenous grafts. Think of failed kidney if the patient already was transplanted, and then this may be an indication for graft nephrectomy. So treatment of inflammation is not only through dialysis management, either by the use of online hemodiafiltration or expanded dialysis, but we need comprehensive overview about the healthy lifestyle and daily use of drugs, plus novel anti-inflammatory drugs and dialysis therapies. So a lot of issues can help the patients for reduction of inflammation. This is why we established a program for renal nutrition fellowship within the Mansoura Faculty of Medicine to have well-dedicated and highly competent nutritionists specialized in renal care. Regarding the infection and the use of procalcitonin, because when we deal with the infections, you'll find many consultants recommending the measuring procalcitonin level. So in hemodialysis, a study addresses the issue of procalcitonin. One of the important message is procalcitonin in dialysis is almost 10 times the normal population. So if it is a normal population 0.03, it is 0.3 in dialysis patients. And another important point, its level is reduced by dialysis. So this is to put in mind. One of the important lessons within this study is the inter-individual variability is there, but intra-individual variability is not high. So the how to translate it into practice? This means if we have the level of the patient, the procalcitonin is already measured, and you follow the level, if it increases, this may be a reflection of infection, because within the individual, intra-individual variability is not high. Regarding latent TB, the best way for screening of latent TB in migrants with CKD is the screening with interferon gamma release assay, like quantiferon, was superior to tuberculin test. And one of the reasons is we have factors in hemodialysis that can affect tuberculin testing, like hyperparathyroidism, because hyperparathyroidism suppresses the T cell immunity. Occult hepatitis C, it is also a very important study published from Egyptian side here, from the Al-Azhar University staff. As you see here, occult hepatitis C is there in 9 patients out of this number of patients. How they diagnose the occult hepatitis C is by doing PCR within the mononuclear cells instead of the serum. So all these patients have negative serum PCR for hepatitis C, but this fraction of patients have positive mononuclear PCR for hepatitis C. So this is a way for this diagnosis. One of the issue that this month we have the release of the KDIGO guidelines for hepatitis C management in chronic kidney disease, and the executive summary is already published here in the Kidney International and within the supplement of International. So you can find a lot of data regarding hepatitis C in hemodialysis. So the current guidelines recommend that hemodialysis facilities adhere to standard infection control procedures, including hygienic precautions that effectively prevent transfer of blood and blood-contaminated fluids between patients to prevent transmission of blood-borne pathogens. Proper hand hygiene and glove changes, especially between patients, patient contacts before invasive procedures and after contact with blood and potentially blood contaminated surfaces and supplies. Proper injectable medication preparations, practices following aseptic techniques and an appropriate clean area, and the proper injectable medication administration practice. Thorough cleaning and disinfection of surfaces at the dialysis station, especially high touch surfaces. Adequate separation of clean supplies from contaminated materials and equipments. They recommend regular observation audits of infection control procedures in hemodialysis unit. They recommend not using dedicated dialysis machines for HCV infected patients. However, if we are in a surface with high risk of seroconversion, I think using a dedicated machine and isolation of the patients, from my point of view, it is wise in these dialysis units. But these are the guidelines, but here, please look at the evidence. 1D means it is a recommendation, but based on the very low level of evidence. Not isolating patients, again, it is suggestion based on weak evidence. Suggesting dialyzers of HCV can be reused, and we are here totally against reuse. In our center, they recommend that hemodialysis centers examine and track all HCV tests results to identify new cases of HCV infection in their patients. And this is the algorithm of management according to the genotype and according to the dialysis. So we are here. If we think of dialysis patients is grade stage 5D means dialysis. According to the genotype, we can select direct antiviral drugs. We are fortunate today because we have drugs that can be given in hemodialysis patients. Regarding predictors of mortality, here protein carbamylation is associated with mortality because of excessive urea, so we should be careful about conducting optimum dialysis. High ferritin, irrespective of the country, this is DOPS study. In the United States, in Europe and Japan, the high ferritin is associated with increased risk of mortality. Relative blood volume outside the range, and how relative blood volume is estimated through this equation that is done semi-continuous. So it can be calculated from the machine by multiplying 100 multiplied by hematocrit on the beginning of that before dialysis, divided by hematocrit within the time of measurements. If we are away from the time, survival. If we are away from the range, the survival is drastically affected and reduced. Vitamin D, according to this systematic review and meta-analysis, including 18 independent studies, 15 prospective, 2 retrospective, and 1 nested case control study. Although there is no randomized control studies, but this meta-analysis demonstrates that hypovitamin D is associated with increased mortality. Missed hemodialysis treatment, we should advocate patients to be adherent to their dialysis sessions. Here, it is funny that in the United States, the percentage of patients who are missing treatments are significantly higher than other countries, and here it is very minimal and negligible in Japan and Italy. And the missing treatment is associated with hazard risks of mortality, all-cause mortality, cardiovascular mortality, and death. Interdialytic blood pressure variability. Here they measured blood pressure through ambulatory blood pressure monitoring for 42 hours, and they found that excess variability in the interdialytic blood pressure was associated with excess mortality. Blood pressure, pulse pressure, and mortality in hemodialysis patients. Here we should look at the accompanying heart failure or atrial fibrillation. Why? Because if there is atrial fibrillation or heart failure, what do you see? The others increased with lowering pulse pressure if there is atrial fibrillation or heart failure. and the hazards is reduced by high pulse pressure. And this is completely contradictory to patients with no atrial fibrillation or no heart failure. Here, the high pulse pressure in traditional patients without heart failure and without AF, the higher the pulse pressure, the higher the hazards ratio for mortality. So the link between pulse pressure is different between patients with atrial fibrillation or heart failure to patients without this complex cardiovascular problems. Hemoglobin variability is bad and is associated as well with mortality, so we should strive to have follow-up, proper follow-up of hemoglobin, and some centers have dedicated clinical pharmacist or dedicated nurse, anemia nurse. Thyroid disorders, high TSH reflecting hypothyroidism is linked with increased all-cause mortality through another predictor of mortality in hemodialysis. Regarding proton pump inhibitors, I am advocating the prescription. The prescription means to use proton pump inhibitors whenever they are urgently indicated and to avoid them on the long term. And we may use them in interrupted or to be replaced by H2 receptor blockers, because here in dialysis patients, PPI was proven to be associated with hypomagnesemia and increasing high mortality and cardiovascular mortality. Another article showed that using proton pump inhibitors in comparison to H2 receptor blockers, proton pump inhibitors use was associated with excess hip fracture. So this is the patients with hip fractures. Here you can find the link with the proton pump inhibitor, and the risk is increased by this from 10 to 28%. Regarding miscellaneous issues, and this is the last part, I am believing in ultrasound, because one of my career is to do echocardiogram for the heart. So I am advocating POCUS. What is POCUS? It is point of care ultrasound. So we can use it in dialysis and in kidney disease patients to even to look at the heart, at the lung, IVC, etc. And this is an example of ultrasound. By just one view to the heart, you can know the valves are working. There no pericardial effusion, so it's very fantastic to look at even to the lung to know the is there overload or not. This is why we incorporated ultrasound echocardiogram in the last international hemodialysis course, and we will give more time for training on ultrasound the next international hemodialysis course for African countries. Dialysis duration and transplant outcome. This is a very interesting point, because preemptive dialysis is associated with better survival. So how if the patient is dialyzed for a very short period of time, according to this very recent data, even the dialysis for a period between less than 6 months was associated with increasing hazard risk of graft failure. So we should not forget to evaluate our patients in dialysis for the transplantation. The best way is to evaluate them for transplanting candidacy before dialysis. The best is to do preemptive dialysis, preemptive transplantation, as to avoid dialysis as we can. The longer time on dialysis, the higher the risk for reduction of graft survival. And this is a fantastic CT scan using 3-dimensional to measure visceral fat and subcutaneous fat. So the red color reflects visceral fat and the blue ones reflect subcutaneous fat. The higher the ratio of visceral fat to the subcutaneous fat means insulin resistance. But here in this study, these patients were evaluated before transplantation, and after transplantation they found that excess visceral fat to subcutaneous fat was associated with impairment of the graft function. It's a fantastic view. This is a patient who is already dialyzed for a long period of time, and he presents with pain here, and as you see here, a defect above the patella. If you have this pain in the joint with a defect above the patella, don't forget the quadriceps tendon disruption because of severe hyperthyroidism, and you can test for extension of the knee joint to be early detected and early dealt with. What's your diagnosis here? If I find this in a dialysis patient, this was a child with dialysis, and if we see this, we can think of calciphylaxis, but the biopsy shows calcium oxalate, so this was a case of primary oxalosis with many problems everywhere. The last point that I want to discuss with you is early dialysis for acute kidney injury indicated or not. This was an answer from the most recent study conducted and terminated because of no advantage of early dialysis in a stage of failure rifle. So it is better to stick to the clinical indication. So the indication of dialysis in acute kidney injury domain is either hyperkalemia, severe acidosis, pulmonary edema, overload. All these are clinical and critical indications to start dialysis. But to do dialysis earlier, and this is the patient, all these patients are acute kidney injury and sepsis. Here the answer was no advantage for encouraging early dialysis in comparison to the standard of care. As you see here, no difference, even survival here. P-value is insignificant, but the curve of delaying strategy, waiting until we have clinical indication even a little bit, shows insignificant superior outcome. The last point is a lot of issues are related to the physician burnout. This is an article outside hemodialysis. It is conducted on 42,000 physicians, and they address the burnout. And the burnout was shown here in this systematic review and meta-analysis to be linked to affect the patient satisfaction and the professionalism of the patients. So we should strive to improve dialysis practice and to improve the the physicians as well as patients. Physician burnout is associated with suboptimal patient care and professional inefficiencies. Healthcare organizations have a duty to jointly improve these core and complementary facets of their function. At the end, this is my journey within the most updates in hemodialysis, but the lesson that I always learn from the update is we should learn and continue learning, because the update is not every month, it's every day, every minute. So we are living because we are learning. And you will find this template. I am very proud of the ES in Egypt Society of Nephrology Virtual Academy, and these are the number of users, and what we add is the index online. And at the end of this presentation, you'll find all the 10th annual conference of Ain Shams University for dialysis and CKD. You will find it on the in the conference sector within this site under 2018. Under this name, 10th Annual Dialysis Conference, Ain Shams University, October 11 to 13, 2018. So before I'm ending this presentation, I would like to congratulate Ain Shams team for conducting a very successful meeting and conference. And always I feel happy if I find appreciation from the doctors who are using the site. And this is one of the letters that I received from Dr. Saud from Eritrea. He was very interested in using our virtual academy and the videos. So I'm happy, and I advocate learning and active learning, because this is our life and this is our mission. Please, if you have any question, please send it to my email. Thank you for your attention, and goodbye.